thank you again for staying. First of all, an apology, I only came back from my own holiday last Thursday from the States, so I had 3 days to do lots of washing as well as doing this, so I've basically got some handouts, so I'm sorry if I've not had time to do a PowerPoint for you. And also I have got a bit of a tickly cough, so sorry about that again. So what I was hoping to talk today was about the impact of 2 workshops that we did a couple of years ago with a local hospice. As part of the university, I'm a link lecturer with this hospice because of my interest in palliative care. So we wanted to do a little bit more work on with unqualified members of staff in rest homes, where often the education is very minimal. Despite the fact that carers often say that they want this education. Also, the context within the UK, obviously we have our National Health Service, which is fantastic, but there's private organisations that do the social and nursing care with a little bit of input for cost from the National Health Service. So that often the homes are divided into a rest home or a care home where there's no nursing need, and then a nursing home where there is more input from qualified nursing staff. So this was mainly aimed at the rest homes where they were unqualified staff and not really supported by nurses, which is what we wanted to try and educate. So how did we do this? So we did some quite simple educational things with the workshop participants about understanding what dementia is and Alzheimer's. Simple things like we got them in a big circle, passed a balloon round so that I mentioned the message, and then we walked round, took people out. So eventually the balloon couldn't get any further. So highlighting that exactly what happens in the brain. So these patients aren't making this up. They really do not remember. The message hasn't got there, which was often a source of frustration when we did evaluations of the first couple of workshops, that they felt that they wanted, they couldn't understand why patients behaved in that particular way. Other things we did was the main one, which a few of the speakers that we spoke about today, getting to know your patients, your residents, really, really important. It's valuing of them as individuals from whatever stage. Now with the rest homes particularly, the residents there are starting from quite good perspective from being able to independence, being able to perform their own activities of daily living, to deteriorating over time and often having to be transferred to a nursing home, which is very distressing not just for the patient and their families, but also for the carers, who it's a long-term relationship and they often get quite close and find it quite upsetting that they have to leave them at the moment of need. So communication techniques obviously really, really important. The specialised care approaches at end of life. So as the patients were deteriorating, we encouraged before the workshops for the care homes to do what we call the success program, which is probably very UK-based. Part of the gold standards framework, which was aimed at nursing homes, lots of education for nursing homes, but not for rest homes. So, sorry? Sorry, I can't hear you. Oh, sorry. It's okay, I'll stay here, it's okay. Sorry, I have a habit of wandering. So yeah, the 6 steps to success was specifically aimed at care homes for their education. So it was building on that and allowing them... Okay, thank you, Kathy, thank you. So, as a result of the evaluation, practical changes were made in the care approaches, which has included implementation of things like Abbey pain scales, so validated pain tools. So when the patients were getting to that trajectory of, how do you recognise pain in someone who's got cognitive disabilities, who isn't cognitively aware, or is indeed unconscious at the end of life. And is a tool actually which is used in people without dementia type problems. Anybody who is unconscious, I advocate using that tool to try and get a more objective measure. So communication strategies, one that the participants found very useful was the toast scenario, as we call it. So a resident would ask for some toast, and we show them different ways of reacting to that question. So one was just plonking the plate down with toast. There you go, there's your toast, going away. Which is okay, you've done what they've asked, but in that context, when someone isn't, might have forgotten they've asked for the toast in the first place, to better communication strategies that opens up avenues for communication, and to try and keep that conversation going, as Magda was mentioning before. So sitting down with them, giving them the toast, oh, doesn't that smell lovely? Trying to encourage the senses to remember. Someone mentioned earlier about senses being so important and often the first ones that are lost. So, look at that jam. Don't those strawberries look juicy? Just trying to encourage that interaction, and also with a smile, and maybe touch, as others have mentioned as well. That's so important to get that connection, make that patient, that resident feel happy that they're being looked after, that sense of belonging, and that they're worthwhile as well. So we did, I say it's a qualitative study, it's very small in nature really, analysed into themes which we called carers' voices, which we felt was very important. And the main one was listening and understanding. Participants strongly advocated the importance of getting to know individual clients, their likes and dislikes, and who they were as individuals. And like Kathy was saying earlier, her children want to get to know this person who did baseball and whatever. Fantastic. My children very much the same with their nana who has dementia, who little old lady with the blue rinse who used to make, was in the bomb packaging factories in the war, and you can't equate the two, but that's what she did. That's what women did in the war. What a different, different perspective. So just a couple of quotes from some of the participants about listening and understanding. One said, especially with dementia, you've got to get to know them, to know their history and their life story. Otherwise, you can't care for them. You can't support them, but you can help bring them back when they're having a bad day. And I thought that was really important, bringing them back when they're having a bad day. And you have to have that connection. If you've not got that knowledge, then how are you able to do that? It's very difficult. And also, if you know them, in some respect, it's easier to pick up the changes in them and find out what's wrong. So whether it's a physical problem, sorry, I'm wondering again. It's a physical problem, such as urine infection, or whether it's a frustration problem, they're not happy with something. It's easy to work out. The next theme was peer support. Participants felt that they benefited very much from actually being on this sort of workshop with other people from other rest homes, which was not an opportunity that they got very often, that networking. It's often the case with qualified nurses. They would maybe go to specific disease-based courses or whatever, but for the unqualified staff, and they did feel very much alone and let down, and they were the most poorly paid, so they felt that the whole, just putting this thing on for them, they felt very much, the self-esteem was improved by it. Empowerment and confidence, that was another theme. With the Abbey Pain tool cited specifically for this, which was one of the tools that we suggested. We did suggest others. We weren't very prescriptive at all. We just show them a variety and what you might find works best within your care environment. It's different in each area, isn't it? But that was specifically cited, and I think possibly because it's shorter than some of the other tools like the DISTATs that we use in the UK. I don't know if you've heard of that one, which does tend to be a lot more lengthy. But the main outcome from that one was one of the quotes. They said it empowers the carers. They feel they've made an assessment and it's more likely to be taken seriously, in brackets, by the doctor, suggesting additional benefits and growth in clinical confidence when using an evidence-based tool in practice. So these, as I say, they're unqualified staff. there might be senior carers, or even a manager, but they felt it just gave them more confidence in approaching the doctor or other specialist services, saying that they needed some help and needed some input. And this also enabled the specialist services to be able to come to the area and to the care home and provide whatever was necessary, maybe refer other specialists to come in, like community nurses, to provide more specialist nursing care, and then so allow that patient to stay in that home right to the very end, which is what the care home staff wanted as well. And they said they verbalised this, gave us the confidence to be able to do that, whereas we wouldn't before. They would have to go somewhere else. And one participant actually got quite passionate about this, saying they managed to get everything in place, so the doctors, support from the doctors, from the district nurses, and she said, for us, that's massive. At the end of the day, what is the point of doing all this training if we can't do it, as in taking care of people at the end of life? And we're not just here for the best bits. And if I'd had my poster, that was one of the big quotes on it. We're not just here for the best bits. It all falls into one package. It's not just a case of bring them into us when they're mobile and self-caring, but as soon as they're end of life, then they have to go. No, and she really was in my face when she said that. No, we're not having it. Communication. So the focus on the workshop was to encourage carers to develop different ways of communicating with their residents. A direct result of attending the workshops was the placing of memory boxes within the care homes. Excuse me. These were situated outside the rooms and just had little tiny mementos just to remind the residents when they were a bit more ambulatory of where their room was. There was mixed reactions from the residents. Remember, one resident had said, oh, I won't need this, I'll be going home next week. And she'd already been there a number of years, which I thought was quite sad, really. But the intent there was to have this focus for communication, that there was keeping the conversation going, as was mentioned earlier, that this conversation, there's always a way of keeping it going and picking out the nuggets, and the memory boxes was a way of keeping them nuggets going. And again, they highlighted the Abbey Pain scale, but not just within the context of assessing somebody at the end of life and symptoms, but also in relation to communication techniques, because it is a very non-verbal way of assessing somebody. And it seemed to be that these care staff were doing this intuitively anyway. If they'd got to know that person, they'd know if someone was wriggling around in the bed or in the chair and didn't look comfortable, or by facial expression or noises that they made or didn't make that was making them uncomfortable. Making an early start. Getting to know the person and how this was communicated to the rest of the team was seen as a key element of the workshops. This was advocated to be, and was started from the admission process to that care home. Getting to know them as an individual for their likes and dislikes, which were all documented within the notes. And in the workshops, we did an exercise where there was about 3 of the lecturers there. We're all talking about the same thing: what we like to eat, what music we like, the colours we like, how decorating your house or whatever, and how different we were. And that was just between 4 people. So imagine the differences in your care home, and try to get the participants to think about it, really, how different we all are, and to not focus on that task-orientated care. It's that individualised, holistic care. And again, this enabled staff to help support the residents better on a day-to-day basis in achieving the things the residents like to do, but also end-of-life issues. So, music that they might like to play. We didn't call them memory boxes for end-of-life, but we used essentially what they would put in a memory box, things like music, and pictures around them, things that they like to listen to, which would as well help with any communication if they were still able to. So one of the participants even suggested earlier interviews would be helpful before any capacity had been lost at all. So thinking about, by the time you've got to go to a rest home or a care home, you've got to go there because some capacity has been lost already. So there's already things you might well have forgotten or need reminding of, and you know there's problems there. So it should potentially be started at diagnosis, although obviously that takes very special phrasing. And that's what one of the carers said. This discussion needs to take place before perhaps they've even got here, as in the residential home, because if they have more severe dementia, then we won't be likely to get that information from them unless the relatives know, which might not be strictly accurate. The earlier the better. So another theme was building trust. So building trust through communication with family carers who sometimes I think can be overlooked once they've got into the rest home, because the carers tend to take over that day-to-day care, and it can leave the carers feeling a little bit undervalued and a bit of a failure if they've had to look after this person for some time and then they're you know, all this is taken away from them. So a lot of the carers felt that was important to you know, have the conversations all together so that the likes and dislikes were discussed together, family life, things they'd done, it was all together so that they could see that their you know, input was really important as well. And you know, develop this open dialogue. Often with families can be a conflict of interest when it gets to consent issues and best interests. We have best interest documentation in the UK where even if you've got an advocate, the carers are encouraged to document things that the residents are saying. So that if they're frequently saying that, oh, I like that there, and then maybe, you know, they might have deteriorated and family want them moving, there could be a discussion, well, she frequently is saying this, and it all comes in as a pack and everything, which if you can open up that communications with the family, it works much better. But as one of the carers says, you just need to keep the family up to date with what's going on in the situation, that what we'd expect to happen, like physical changes at the end of life. Not everybody is aware of what happens at the end of life, the noises people make when they're breathing or how they might look. It can be quite distressing. And if there's anything they don't know, then they can always ask, just to keep that open dialogue. We don't want anything to be a shock. The wider team, other community teams can be a useful source of information. As I said, district nursing teams can help at the end days of life with drug therapies, etc. Syringe drivers. Also, occupational therapists, community mental health teams, all can go into these care homes without necessarily having to transfer them into a nursing home, which is what the carers seem to be suggesting they wanted. And ensuring that the residents' preferred place of care was realised, which is another document to do with palliative care in the UK, that they want, when you're cognitively aware or you're diagnosed with a disease, that you can put down on paper. It's not written in stone, you can change your mind, but that you can say where you want to be looked after at the end stages of your life. So the majority of the participants described this input as brilliant and fantastic, and they felt that they wouldn't have been able to keep that resident there if their input hadn't been going. So it was great collaboration to see those services working together. And also these other specialists gave them other ideas on how to work with a patient, especially have more demanding behaviours. They just give them other ideas and a springboard as well. And it was very important that they felt that they weren't there to take over, and it was still, you know, because these teams would be coming in and out, you know, maybe an hour at most, and it was left to the carers then to look after these people. So they had to give them the strategies to be able to do that. Documentation processes. I think this was the last theme that we came up with. I've mentioned briefly before about the preferences, and they would have to obviously document what had happened during the day, and they said you can't just write "had a good day." Has to be more in depth than that. If they express a wish to us, we have to put that in, and everything they have done throughout the day is written down. And the participants felt that the majority of residents fulfilled their wish of staying within the home at end of life, rather than going into hospital or, like I say, a nursing home. So, just to sum this up, so the findings suggest that in order for comfort and communication measures at end of life to be fully implemented, 5 key requirements need to be met. Time needs to be spent getting to know the individual resident so that the person feels safe within that care environment. As others have mentioned, other speakers, the importance of interpersonal interactions, keeping the conversation going, and the poem Kathy read out yesterday, just be with me. It doesn't matter what I'm saying, really, that might come out as complete gobbledygook, but just be with me. And I know my husband finds that difficult with his mum with the Alzheimer's. You know, it's very repetitive, and he finds that quite difficult. It's finding the nuggets each time. Effective means of documentation, so that, say, you might know your residents very well, but what happens when you're on holiday? What happens when, you know, someone goes off sick, you get a new member of staff? What do you do then? There's lots of different ways that the homes were advocating that they did, so that, like, one-page profiles, you know, a quick summary for a new member of staff, but then that one-to-one mentoring with that resident as well. A supportive culture is a really big thing, really. If the culture of that home isn't one of empathy and caring, then the staff won't be like that either. The staff have got to be empathetic to perform the care, to get through to the communications, to help them residents feel comfortable and safe. But also, as well as that, alongside that, the effect on the carers as well, the carers' needs. If you've got a long-term relationship with someone who's been in your care for years, as was with mine when I was a district nurse years ago, when that person does eventually die, it can be quite, you know, you've got close to them. Yes, a professional relationship, but it's still, you know, it's of a long time. There's a feeling of sadness. So the organisation needs to show ways of supporting that, which many of them did, and which was really good to see. And finally, need to develop more robust methods to ensure these conversations occur at a much earlier stage of the illness, and even possibly at diagnosis before capacity is lost. And I would say that not just for this condition, but for lots of conditions as well. We all need to start thinking about what we want to happen before we get there. Thank you very much for listening.